Right. So this presentation is Parkinson 101. It will cover a little bit about what Parkinson disease is, some treatment options, and then a little bit about our organization, Parkinson Association of Alberta. So what is Parkinson disease? This is kind of the biggest question we get. It's defined as a chronic progressive neurodegenerative disease, which is a lot of medical terms, but we'll break down. So it's chronic because it's longstanding and persistent. Once you're diagnosed with Parkinson disease, you will live with that diagnosis for life. It's not a terminal diagnosis per se, but it is one that is longstanding, and it is progressive as well because it does gradually develop and worsen over time. And then it's neurodegenerative because it involves the deterioration of cells in the brain, which we'll talk about in a little bit. The cause of Parkinson's is unknown and our cure is also unknown. So there's a lot of gray area with Parkinson's. There's a lot that we're still trying to figure out with research. This presentation will shed light on what we do know about Parkinson's and hopefully provide some more information. And then hopefully in the future, research will give us some more information about what we don't know. So this slide here talks about the onset of Parkinson's. I normally look at the Alberta number, which is 11,500. It is likely a little bit higher than that. There's no formal registry for Parkinson's, so this is kind of an estimate based on what we know worldwide, but it is the fastest growing neurological condition. So like I said, that number is probably higher and is expected to double and possibly triple over the next few years as our population ages. And so we're seeing Parkinson's a lot more. It's becoming a lot more prevalent. It is deemed the second most prevalent neurological condition behind Alzheimer's disease. It affects more men than women. The average age of onset is about 58 years old, so anyone younger than that is deemed a young onset diagnosis. The last bullet point there says that being diagnosed before the age of 40 is a young onset diagnosis. Some neurologists in Alberta will use the cutoff of 50, but between 50 and 40 is what we consider young onset. So someone like Michael J. Fox, who was diagnosed in his 20s, I think, was considered a young onset diagnosis. And the majority of people with Parkinson's are 65 years or older. So it was kind of previously thought of as an older person disease. That's not necessarily the thinking anymore now that a lot of folks with young onset Parkinson's have come forward and are making a lot of stride in Parkinson research, but it does target an older population for the most part. So the cause of Parkinson disease, like I said, it's unknown right now. What we do know is that the symptoms are caused by a lack of dopamine in the brain. And so the dopamine cells are in this, what is around this red box here, the substantia nigra. That's where our dopamine cells live. And so what happens in Parkinson's is those cells start to deplete and start to die. And then there's not enough dopamine in the brain to move or to regulate movement like a person used to. And so they say that by the time somebody has significant enough symptoms to make a diagnosis of Parkinson's, about 80% of that dopamine is already gone. So those cells are likely depleting for many years, and it is quite subtle. But then by the time we see symptoms, about 80% of it is gone. And dopamine is responsible for many things in our body, mood being one of them, but movement is the biggest one. And that's why Parkinson's is considered a movement disorder. So again, caused by the lack of dopamine from those cells dying off. And then the other area of thinking is maybe it's genetic, maybe it's environmental. Why are those cells starting to die? That's kind of what we're trying to figure out. So genetics, they're looking at different genes or maybe something happening in those genes that's causing Parkinson's. Alpha-synuclein is kind of a buzzword for Parkinson's and genetics right now. There, if you're reading anything about Parkinson's, you'll hear about alpha-synuclein quite a bit. That's one of the bigger things that they're looking at genetics-wise. Michael J. Fox is also doing a lot of research on genetics, and so he's found something with biomarkers and Parkinson's that can hopefully detect Parkinson's earlier. So they're using a spinal tap to get that. So making quite a lot of headway on genetics and Parkinson's and kind of getting some more answers there. The other area of thinking is environmental. So things like pesticide exposure, consumption of well water was previously thought of maybe a cause of Parkinson's, toxins, exposure to chemicals, head trauma. Those are all kind of things that we consider in environmental factors. And so head trauma, we're looking at things like a very significant head trauma or repeated head trauma, something like a concussion. And so a lot of sports-related injuries or sports-related diagnoses of Parkinson's, a lot of those sports people relate it to the concussions and head trauma that they experience. So Nathan Dempsey, he's, I believe, a hockey player with the Oilers. He has young onset Parkinson's, and he believes that it might be from the head trauma. And a lot of football players have recently come forward and say they have Parkinson's, and they believe it's from the concussion. So that head trauma might be causing those cells to die off. Things like pesticide exposure or occupational hazards and lifestyle changes Those kind of tie in with genetics as well. So genetics and environmental are not completely isolated factors. They are thinking that if you look at a family, let's say in rural Alberta, where multiple people in that family have Parkinson's, if they're all doing the same occupation, they're all farmers, let's say, they're all using the same pesticides, they're all eating the same diet, living the same lifestyle, consuming water from the same source, exposed to the same toxins, perhaps. They also have similar genetics. So if something is happening in those genetics, it would make sense that multiple people in that family have Parkinson's. So they are likely tied. It might be a combination of the two factors that come together to make Parkinson's, but this is kind of an area of research. The other kind of thing they're thinking is maybe it's starting in the gut and then moving to the brain. That's also an area of research right now. So this is kind of a question mark for us right now, but hopefully in time we'll get some more information here. When we talk about Parkinson's, we also have to talk about Parkinson plus syndromes. And so we use the term Parkinson plus. A lot of neurologists will use Parkinsonism, atypical Parkinson, or Parkinsonian syndromes. They all mean a set of syndromes that look like Parkinson's, but behave a little bit differently and have some of their own features and associated symptoms. And so the best way to describe it is kind of like the cousins to Parkinson's. They look like Parkinson's, but they are slightly different. And so the main differences between Parkinson plus and Parkinson's is that the Parkinson plus syndromes have limited or no response to the main medication, levodopa, which we'll talk about in a little bit. They have a lack of or an irregular resting tremor. So the tremor is a little different and it can happen in different places in these syndromes. Symptoms are present on both sides of the body at onset. So with typical Parkinson's, it's usually unilateral. With Parkinson plus, we can see it on both sides sometimes. There's earlier issues with balance, cognition, speech, and swallowing, and they progress a lot faster. So these conditions are more debilitating within the first 5 to 8 or 9 years with the disease, whereas with typical Parkinson's, you usually have a little bit more time, but these guys are moving quite fast. So there's 4 Parkinson plus syndromes. Most people who have these diagnoses just go by the abbreviation because the names are quite long and hard to remember, which I don't blame you. So the first one is progressive supranuclear palsy, or PSP. And this is where a person would have Parkinson's symptoms and then also have a lot of vision issues that are coming with it. So difficulty kind of regulating eye movements, things like blinking, moving your eyes up and down or side to side. Some people have described almost like a tremor, like a palsy in their eye, kind of like a shaking, difficulty with blurred vision or double vision, kind of a lot of vision changes and Parkinson's symptoms happening at the same time. With multiple system atrophy, or MSA, it's Parkinson's symptoms and then a lot of symptoms with autonomic dysfunction. So difficulty regulating heart rate, blood pressure, bowel control, temperature, anything that your body kind of does normally can become impacted by MSA. Cortical basal degeneration, CBD, sometimes called cortical basal syndrome. So if you're looking at research, it might say CBS instead. And with this one, it is Parkinson's symptoms and then early issues with falls and balance issues, and then also a lot of speech issues as well. So things like slurred speech or pauses in speech patterns that are not quite normal, changes overall to the speech, but then a lot of issues with balance and falls, like I said. And then dementia with Lewy bodies. This is one that I think most people have heard of before. This is where the Parkinson symptoms and dementia symptoms are kind of coming hand in hand. So it might be a Parkinson diagnosis followed very closely or a year after with a dementia diagnosis, or the two happening at the same time. And so there's a lot of memory issues here, as well as typical Parkinson symptoms, which we'll talk about. So how is Parkinson disease diagnosed? It is kind of a tricky one to diagnose. It usually begins with a physician, your family doctor. Most people will go to their family doctor and say, I'm noticing these symptoms. What can we do about it? The family doctor will look at the medical history, take a look at the symptoms that are being shared, and then usually will make a referral to a neurologist. And it's usually a neurologist who makes the final diagnosis and prescribes the medication and then handles your care with Parkinson's going forward. There's no formal blood test, scan, or lab exam that can definitively diagnose Parkinson's. Sometimes they'll use other tests like an MRI or a PET scan to rule out other conditions and make sure that there's nothing else happening. If those come back clean in a sense, then they say, okay, we're thinking it's Parkinson's. They also can use the medication as a diagnostic tool. So if they prescribe the medication and it works well for people, then that usually points them in the direction of Parkinson's. So they're really using medication, but then also symptoms. They're really looking at your symptoms here. And we're looking for 2 out of the 4 main motor symptoms to make a diagnosis of Parkinson's. So the main motor symptoms, the first one is tremor. This is kind of a hallmark symptom of Parkinson's, right? When we think of Parkinson's, this is what we think of. The tremor is a tremor at rest, and it disappears with intentional movement. So when someone is, let's say, just sitting on the couch relaxing, you might see their tremor. If they go to grab their cup of coffee, or if they're going to play pool, let's say, you might not notice that tremor as significantly. Although stress and excitement can make it worse. So if a person is feeling really stressed, you might see their tremor no matter what. Like I had said earlier, it usually only affects one side of the body. It's pretty unilateral. I think it's important to note that not everybody with Parkinson's has a tremor. I think they say it's about 80% of people who have a tremor. So it is quite a high percentage, but not everyone with Parkinson's has tremor. There's also something called essential tremor, which we get asked about quite often. An essential tremor is different than a Parkinson tremor. An essential tremor is an action tremor. So when a person is going to do something, you'll see that tremor a lot more significantly than when they're at rest, which is the opposite of a Parkinson's tremor. That's kind of the difference there. The next one is bradykinesia, or slowness of movement. This is a general reduction in spontaneous movement. So reaction times can also be slowed during this. It's just a lot harder for people to get going and to make spontaneous movement. People with Parkinson's are moving about 3 times slower than people without Parkinson's. That's kind of the best way to describe that slowness of movement. The next one is rigidity. So this is a stiffness or inflexibility, usually in the neck, limbs, or trunk muscles, but it can kind of be all over. Some people have described it as feeling like their muscles are constantly tense, or feeling, one I heard one time that was a good one, was they feel like the Tin Man and they need oil in between their joints to get moving. There's not enough oil, there's not enough dopamine in the body to move like you normally would. So it can create a lot of stiffness. Stiffness in the neck is a really common one that we hear, which can create some difficulties if you're driving and you're trying to shoulder check, or just doing kind of day-to-day things. That stiffness can become a little bit of an annoyance. And then postural instability. So this is when the posture becomes stooped. So you might see people kind of hunched forward, their shoulders kind of rolled forward, maybe leaning forward slightly. This can lead to some balance issues. If you're kind of leaning forward, then you may have a tendency to kind of fall forward, or have some balance issues, which balance issues are another part that come with Parkinson's. And this one, so when Parkinson's was first described by James Parkinson, he had a drawing of a man, and the man has this stooped posture. So if you ever look up James Parkinson, he called it a shaking palsy. That was before we had the term Parkinson disease. But if you look that up, you'll see in the image kind of his posture is quite stooped. And I think the tremor was the main thing that was described at the time. So the postural instability and tremor were things that we really knew about Parkinson's. The slowness and the stiffness kind of came later. And there's definitely more symptoms to talk about, but these are the main 4. So when a neurologist is making a diagnosis, they're looking for 2 out of the 4 of these. So then some of the other changes that can come with Parkinson's, there can be some walking changes. So some people notice that they have kind of shuffling steps, that their base of their feet are quite close together. So then it leads to these small kind of shuffling steps, which can lead to a fall, which can be worrisome. A lot of people with Parkinson's find they don't swing their arms when they walk. It's usually a care partner or family member that notices this first, but one arm is kind of just stuck to the side of their body as they're walking. Some people with Parkinson's have difficulty turning, or the difficulty freezing, which we'll talk about at the end here. And then difficulty with changes to flooring patterns sometimes can happen. And there's quite a few walking changes that can happen with Parkinson's, but the shuffling steps one, I think, is one that we see quite often. Balance difficulties and postural instability, we talked about a little bit already, and that can lead into some of the walking changes and walking difficulties. The next one is decrease or loss of facial expression. So we tend to call this a Parkinson mask. And what happens is we don't see as much facial expression or changes to facial expressions on a person's face. The idea is that there's a lot of muscles that go into our face and making our facial expressions. And people with Parkinson's don't have enough dopamine to make those muscles work like they used to. So things like smiling or frowning can become a lot harder. Again, the person with Parkinson's typically doesn't notice this. It's usually family and friends around them that notice a change in their facial expressions. The next one is trouble with swallowing, choking, and drooling. So same idea about the muscles. There's a lot of muscles that go into the process of swallowing. When we don't have enough dopamine, swallowing becomes a lot harder. It's harder to get to clear things and get food and liquid down, which can lead to choking, which can be quite hazardous for people with Parkinson's. Drooling, sometimes people have an excess production of saliva, and if they're not able to clear it by swallowing, it does have to come out somehow, and it usually tends to come out in drooling. So that can be part of Parkinson's. Some people are on the other end of the spectrum and have quite a dry mouth from Parkinson's medication, and so that's not a concern for them. But swallowing is something to definitely be aware of. I think it happens usually later in the disease, so important to really get some exercises and try to strengthen that swallowing if you can early on. Speech is softer and harder to understand. Our vocal loudness and tone can change with Parkinson's, and so your speech might change. It might start quite loud and then get quite quiet to a whisper. It might just kind of always be at a whisper. It can be quite difficult. Again, a lot of vocal exercises can help with that to try and strengthen it. Small handwriting and difficulty with fine motor movements kind of go hand in hand. So small handwriting is usually a precursor to the disease. You usually see this before people are diagnosed or kind of early on in their diagnosis. And they find that their handwriting becomes really small, kind of scratchy and hard to read. Sometimes it can start okay, and then it gets really small and hard to read. And it is the idea that, again, there's not enough dopamine in the system to make our muscles move the way we need. And there's quite a lot of muscles in our hand that go into our fine motor, things like writing. So things like writing, zippers, buttons, tying bows, all of that can become more difficult for people with Parkinson's because they don't have the same dexterity and movement in their hands like they used to. And then freezing. This is kind of a unique one to Parkinson's. It doesn't happen in a lot of other conditions. And for people with Parkinson's, it's the feeling that their feet are kind of just glued to the floor or cemented to the floor and they can't move. Sometimes you'll see people's upper body kind of move, like they're trying to get going again, but their feet are just kind of glued to the floor. Usually only lasts a couple seconds or minutes at the most, and then people are able to get moving again. Sometimes people need little tips and tricks to get them moving, like singing or counting, or, kind of a gentle tap on their leg as a reminder to get moving. Can happen during off periods of medication, which we'll also talk about in a little bit, but kind of a strange one to Parkinson's. And I know a lot of people find it can be troublesome when they're out in public, right? If they just kind of are frozen and people around them don't necessarily understand what's happening. Can be pretty common if people are changing flooring patterns. So if they're going from a carpeted area to a tile area, or if they're turning a corner, they might feel that turning that corner is difficult, so they freeze kind of as they're going. But usually people are able to get moving again. So this is a long-ish list of symptoms that can happen. It's important to note not every symptom will happen to every person at the same time or same severity. Parkinson's is really unique. So you might have a few out of this list. If you have Parkinson's yourself, you might say, okay, yeah, I've got some of these. Some of them happen later in the diagnosis, like issues with swallowing. But yeah, important to know what could happen, but important also to know that it might not happen to everyone. All right. Then we have the non-motor symptoms. So this is kind of a newer area that we've been talking about. It wasn't something that was talked about much previously. And a lot of people with Parkinson's have told me that the non-motor symptoms are usually what's more impactful to their day-to-day. A lot of people are able to manage their tremor. They just know that it's part of them now, and they kind of manage their day-to-day with that. It's the non-motor symptoms that can be harder to work around. So with Parkinson's, there can be mood changes, mostly depression, anxiety, and apathy. And apathy is kind of that difficulty to get motivated. This can be from the diagnosis of a chronic condition. That's a really hard pill to swallow for a lot of people at first. It can just be part of the disease itself. It can be attributed to the chemical imbalances that are happening in the brain due to the lack of dopamine. For most people, these are manageable with medication or with professional support. So if that's something that you're struggling with, I would urge you to reach out and try and get some support as early as you can. The next two, sleep disturbances and fatigue, those two are kind of connected and they go hand in hand. So sleep disturbances can be things like difficulty getting to sleep and difficulty staying asleep. It can also be things like REM sleep disorder. It can be things like insomnia. It can be active, like acting out your dreams, vivid dreaming. There's a lot that kind of comes in the sleep disturbances that make people not able to sleep and get a full rest overnight. So then they often wake up quite fatigued. They spend their day fatigued. Some people will often have a nap kind of midday. And then if they've had a nap in the day, sometimes they struggle to get to sleep at night. And then it's kind of a vicious cycle that can continue. So if that's something that you're struggling with, really important to seek medical help and see if there is some suggestions or solutions that you can to make sure that you're getting a good night's sleep so that you're ready to take on the day and better able to manage your symptoms. The other part of fatigue with Parkinson's is kind of a body fatigue that's not fixed by sleep. So for a lot of people with Parkinson's, if they're having tremor or if their body's kind of constantly in motion, if your body's always stiff and rigid, that is really exhausting for people. So that in itself can be physically exhausting. Even if you take time to rest, you might not feel like that physical exhaustion has gone away. So a lot of people have said that they have this kind of full body fatigue that often isn't helped by sleep. But sometimes the medication can help manage those symptoms. And then people often feel that that fatigue is manageable. The next one, constipation and urinary problems. So constipation is the same idea with the muscles not working quite like they used to. So inside our body, things are not working quite like they used to with Parkinson's. And so it's a lot more difficult for people to clear their system of what they've ingested during the day. And so it kind of does get stuck and they often feel quite constipated. This is usually pretty manageable. Sometimes dietary changes, sometimes adding something like Restore Relax into the diet can really help. If it's becoming a problem or you have not had a bowel movement in multiple days, then definitely seek some medical help. Really important to get this under control as soon as you can because it does affect how well the medication is absorbed. So constipation is really one that you want to nip in the bud as early as possible, also for your own comfort. Just kind of get that under control if you can. Urinary problems is having to urinate more frequently with a lot more urgency, which can tie into the sleep disturbances because a lot of people find that they're up in the middle of the night to use the washroom and then they're up and they can't seem to get themselves back to sleep. So often recommended to kind of reduce your liquids closer to bedtime. Some people use a commode or some other suggestions to kind of make sure that they don't have to get up fully to go to the bathroom. But yeah, this is one also to talk about with your healthcare team if that's a struggle for you. Sexual dysfunction can happen with Parkinson's, and there can also be some cognitive problems as well, changes to your memory, your thinking abilities, and your concentration. So again, a list of things that may happen with Parkinson's, not necessarily at the same time or same severity. There's a lot of solutions for these, which is really great. And so if you're struggling with any of these, please talk to your medical team and see how you can get those worked out. Oops. So we've got a quote here. It says, if you've met one person with Parkinson's disease, you've met one person with Parkinson's disease. So I've mentioned it a couple of times now. Parkinson's is really unique. Everybody looks so different with Parkinson's, and the way you progress is different than the way someone else will progress. The best example I have of this is Michael J. Fox, who I think we all know very well. He's got Parkinson's. He's kind of constantly in motion. We see a lot more movement with him. But then if you look at him compared to someone like Muhammad Ali, who was very stiff and rigid and who didn't have a lot of movement, two people with the same diagnosis, but two very different ways of presenting. And so just remember that your loved one might not be the same as someone else you know, and important to really take note of your own disease and what is happening for you. All right, then we'll talk about treatment. So like I said, there's no cure for Parkinson's, so treatment is really aimed at alleviating the symptoms. Medication is kind of our best line of defense for Parkinson's, followed very closely by exercise. Sometimes things like physiotherapy, occupational therapy, and speech therapy can be really helpful for Parkinson's if those are done safely. Social work and counseling is often very helpful for the non-motor symptoms that come with Parkinson's. And then there are two surgical options for Parkinson's, which I'll talk about after the medication. So medication is kind of the most important part of a person's care with Parkinson's. It is solely for symptom management. The medication will not stop or slow the progression of Parkinson's. It is just going to manage your symptoms. And it is mainly for the motor symptoms. It works on the dopamine systems in the brain. So it'll either replace or mimic dopamine, or it'll stop the breakdown of dopamine so that the brain has an opportunity to use it up. So there's only one medication listed on here. There are many other medications. And if you're interested in learning about the other medications, there are some courses that we offer in partnership with Alberta Health Services to talk about medication, and they're done by nurses. So I'll leave that to the professionals. What I will talk about is levodopa, sometimes called Sinemet, which was the brand name for the medication. Also available in a form called Prolopa, or we often call it levodopa carbidopa, which is the medication name of it. And so this medication, discovered in the 60s, has been kind of the best medication for Parkinson's. We haven't found anything that works quite like it. And it does work for the majority of people for their journey with Parkinson's. So it is quite a good medication. It just replaces the dopamine that the brain is no longer making so that your movements can be a little bit more smooth and a little bit more coordinated like they were before your Parkinson diagnosis. So the timing and the amount of medication will vary from person to person. Most people with Parkinson's will likely take this medication multiple times throughout a day. It's not a kind of one pill in the morning and then you're good to go. You'll likely need to take it multiple times in a day. And it can be, like I said, added with other medications that help it work better, but often this is kind of the medication that most people are on and that we see most often. When we talk about medication, we also have to talk about side effects. This comes with every medication, but there's quite a long list for Parkinson's here. So when we talk about medication, we really talk about on and off periods. And so an on period is when you're feeling your best from the medication. It's working to relieve symptoms. Maybe your walking is back to the way it was pre-Parkinson's, or your writing is a lot better. You feel less rigid, or you feel less tired. Kind of this is where you want to be in an on period. This is where you're feeling your best, you're feeling optimal. That will only last for a certain number of hours, depending on the person. And then you'll go into an off period. And an off period is where you're seeing a lot of symptoms. Maybe you're feeling more rigid. Maybe your tremor's more impactful. Your writing is a little bit harder to read. Swallowing is becoming a challenge. Speaking might be more of a challenge. You might be freezing quite a bit here. This is not an ideal place to be, but everybody does hit that spot. And that is kind of your body's cue to you, okay, it's time for your next dose of medication. And so people with Parkinson's are kind of on a roller coaster with their medication, right? They start in an off period, they take that dose, they get into an on, they start it off, they take the dose, they get into an on. That lasts for so long, it starts to wear off. They go into an off period, they need their next dose, they're back into an on period. When you're in your on period, you're in this therapeutic window. That's where you're feeling your best. With Parkinson's, that therapeutic window does get smaller and smaller. So sometimes people will need more medication or medication more frequently to get themselves into that therapeutic window where they're feeling on. And so often when you're speaking to a neurologist, if you have a diagnosis of Parkinson's, they'll ask about on-off periods, and that's what they're asking about. On periods when you're feeling relief, off periods where you're feeling symptomatic. And what's the time in between your off periods, or what symptoms do you feel at an off time? So this can be important to track and share with your neurologist so that they can understand how the medication is working for you. If you need to increase, if you need to do it more frequently. So this is a part of Parkinson's. As the disease progresses, that roller coaster can get kind of closer together. Usually it's pretty drawn out at the beginning, but then as you progress, your highs and lows might be closer together. The next one is dyskinesia. So this is a symptom that we see in Michael J. Fox. If you've ever seen a video of him, he's usually in quite a bit of motion. It's these kind of squirmy, uncontrolled movements. Sometimes it's like a rocking back and forth. Sometimes it is kind of just in the head and you notice bobbing or kind of rocking in the head. Sometimes it can be a full body sensation where the person is constantly in motion, which we see in Michael J. Fox. And so dyskinesia can be, it can happen if you take too much medication and you go past your peak, you go way past an on period. That means you're over medicated and you've taken too much. Dyskinesia can be a side effect of the medication. Sometimes that comes, sometimes it can just be a natural part of the disease. Hard to tell where it's coming from, but they have another medication called amantadine that they can add to your routine that often is very helpful to manage the dyskinesia. Nausea is another one that can happen with Parkinson's. This usually happens at the beginning of a person's journey with Parkinson's while they're getting used to the medication and their body's, kind of adjusting to it. Usually only lasts, I would say, 3 to 6 months, and then most people are able to kind of manage it. If it's a recurring issue for people, it's often recommended to take your medication with maybe crackers or applesauce or banana or something so that you're not taking it on a completely empty stomach. Sometimes changing to the version of the medication called Prolopa can help with nausea. That one seems to be a little bit more gentle on the stomach. And then sometimes they have to add another medication to help with the nausea. So if this is something that you're really struggling with, again, speak to your healthcare team and see what suggestions are open for you. But hopefully it is something that will just pass as your body gets used to the medication. Postural hypotension is a quick drop in blood pressure, which can happen from the Parkinson's medication. So this often happens when people go from a laying to a sitting position or sitting to standing. And it is just, quick drop in blood pressure. People often feel quite dizzy. This one is usually manageable with dietary changes. So just making sure you're getting enough water, some lifestyle changes, making sure that you're giving yourself enough time to move. If you're in bed and you're laying, sit for a little while before you get up and stand. Don't just roll out of bed anymore and go. Really give yourself the time. And just, try to keep track of this as best you can. Some people, if they're on blood pressure medication, might need to get that readjusted with their healthcare team. A neurologist once told us, oh yeah, increase your salt intake. She was encouraging everyone to eat chips. And I thought, oh gosh, everyone's going to be eating all these chips now and say, oh yeah, the doctor told me so. But if this is a concern for you, it's worthwhile to speak to your healthcare team and see if there are some dietary changes or work with a nutritionist that might be helpful. The next one is hallucinations. So this can be a side effect of the medication, or it can happen from the disease itself. Hallucinations are usually visual, sometimes auditory. So it's usually kind of something in the corner of that person's eye, usually something quite small, often something that's familiar to the person. So in that sense, it's not threatening to them. I often hear, oh, I see a squirrel in a tree, and that's the hallucination, or a small dog, their childhood dog. It's usually more concerning for the people around them because we don't see what that person is seeing. The hallucinations, it can range on how long they last. They often are more common in low lighting. So often at night, they're really common. Some people may see a chair and think that that is something else. And so if you're having hallucinations, important again to talk to your healthcare team, see if they can make adjustments to your medication to rule that out. If there's other medications they can add, and then there might also be some at-home suggestions that you can do. So things like adding in a night light to make sure that it's well lit and that you can see, which can also help if you're on your way to the bathroom in the middle of the night, you see where you're going. And yeah, just kind of making modifications to your lifestyle to manage those hallucinations if that's a concern. Excessive daytime sleepiness, we talked a little bit about when we talked about sleep disturbances and fatigue, but people often feel quite tired and feel that they may need to nap, and this can be a side effect of the medication as well. And then compulsive behaviors, this is a side effect of one of the medications that I didn't mention, but that's called Mirapex or Pramipexole. And it can be anything that's kind of outside of the normal routine for people. So the descriptions that are given or the examples that are given when you get the medication are things like excessive gambling or drinking or shopping or eating or sexual behaviors. Those are kind of the very extreme ends of it. Sometimes it can just be something that's out of the norm for you. So if every night you have one little square of a chocolate bar and then all of a sudden you're eating a chocolate bar or two, that's an excessive behavior that's outside of your norm. It may be a compulsive behavior caused by the medication. So often, if that medication is prescribed, it's monitored quite closely by neurology. And so it's sometimes managed quite quickly. If it's something that you're noticing is happening, please talk to your healthcare team about it. It is not something to be embarrassed about. It's a side effect of the medication, and it's really important to get that under control before something more extreme happens. All right, and then exercise. So like I said, this is kind of our second best defense for Parkinson's. Our neurologists and a lot of research is now saying that exercise is kind of equal in importance with medication, but it is really good for Parkinson's. It can help you kind of manage your symptoms a little bit better, feel a lot stronger, feel a lot better. So, I mean, exercise is good for all of us, but for Parkinson's, it can really strengthen your muscles, enhance your mood, which can help with the non-motor symptoms. It can prevent falls as well, or if you do have a fall, it can maybe minimize how significant the injuries are, or if you're exercising well, you might be better able to get up from that fall, and it can help you more easily cope with the symptoms of Parkinson's. And so the question we get asked often is what kind of exercise is the best? We normally recommend something that you enjoy doing because you're more likely to do it and make it a routine, make it a habit, and do it daily. There's a lot of research that show things like Tai Chi and yoga are really good for Parkinson's because they focus on slow but intentional movements, which can be really good for Parkinson's. Boxing, surprisingly, is good for Parkinson's. I feel like after people heard Muhammad Ali had Parkinson's, they thought, no boxing. But it can be quite good for Parkinson's for hand-eye coordination, balance issues. It is quite a full body workout, so that can be really good for Parkinson's. The other one is it is a program that was created specifically for Parkinson's. It's called Power Moves. It's spelled PWR. It stands for Parkinson Wellness Recovery. And it was a program by a woman made in the States, and it focuses all on Parkinson's and symptoms, or it targets symptoms of Parkinson's. So it focuses on really big and exaggerated movements because we find with Parkinson's, people can get quite small. So maybe you're reaching, but you're not reaching quite as high as you need to or quite as high as you think. If you're walking, maybe you're not lifting your foot quite as much as you need to clear that step, things like that. So it focuses on these really big and exaggerated movements. There's often a vocal and a cognitive piece that go with it. So it is a full body workout. We have a couple offerings of it here in Alberta. I'm sure there's some stuff online as well. That's a really good program. But if you're needing help finding a program in Alberta, please just give us a call. We're happy to let you know what we offer that can help with Parkinson's and get you involved. All right, the surgical interventions we'll talk about quickly. So there's two. They are both available here in Alberta, and they are both covered by Alberta Health Services, which is amazing. The first one is deep brain stimulation, or DBS. This one is often good for people who are struggling with motor symptoms, things like tremor or dyskinesia. This surgery, I won't go into too many details about it. We have some information about it through our organization if anybody's interested in more, but it is brain surgery that involves implanting wires into the head that get under the skin. They're connected to a device in a person's chest, similar to a pacemaker, but it sends electrical impulses through the wires to the area of the brain that are causing symptoms, and it helps manage those symptoms. Quite effective for people. It is quite an undertaking to undergo surgery, and there are some eligibility requirements, age and cognitive functioning being one of them, and response to medication being another. So if this is something that you are potentially interested in or curious about, I would definitely recommend asking your healthcare team. Here in Alberta, we're very fortunate. We do the surgery out of Calgary and out of Edmonton. So we have a handful of neurosurgeons who are able to do this, and we're very fortunate to have that. This can also really help reduce the amount of medication a person is taking. I know people who have had the surgery who have gone from, let's say, 24 pills down to maybe 12 or 16. So it can cut back how much they're taking, which can be quite helpful. And it just really helps manage the symptoms. The second one on here is duodopa. So this one is slightly less invasive. It involves an insertion into the stomach that goes straight to the small intestine, and then it gets connected. You can see here the tubes that get connected into this device that's in his hand with this part at the top. It's gray here, but usually gets filled with a gel form of the medication. They call that a cassette. And then the gel medication goes through the tubes right into the stomach. And so this is really good for people who are struggling to find stability and balance with their medication. If they're kind of on this crazy roller coaster, having lots of off periods, unable to manage, if they're taking a lot of medication throughout the day, this is a really good alternative because it gives them a steady flow of medication throughout the day. This one, like I mentioned, covered by Alberta Health Services for the surgery, and then there's often some help with the medication, and they will send the medication right to you. You'll kind of put in a new cassette, which has the gel medication in the morning, often wear it throughout the day. A lot of people do take it out at night and don't sleep with it, so they might take oral medication overnight, and then you are not supposed to get it wet, so people will often shower, swim, whatever they need to do in the morning, and then kind of get it set up for the day, and then it helps them manage throughout the day. Eligibility for this one is often response to medication, and then they've got some surgical eligibility that they'll go through with you as well. But this one can be quite helpful to, like I said, find some stability and eliminate the use of oral medication because you're getting a steady flow right into the system. So again, the two surgeries that are available for Parkinson's, if you're interested in learning more about these, please just give us a call. We're happy to share some more information or talk to your neurologist about these. All right, and then Parkinson's research, I've mentioned a little bit before. We always have research ongoing. Again, here in Alberta, we're very fortunate. We do research out of the University of Calgary, the University of Alberta, and the University of Lethbridge. And so there's a lot of research happening for Parkinson's, which is very exciting for us. We're happy to be involved. Our organization does contribute to research, and then we often have news about Parkinson's research if you're interested in getting involved. Research right now is really focused on genetics. Like I was saying, Michael J. Fox has a big focus on genetics. Here in Alberta, more so finding ways to manage symptoms that are coming with Parkinson's and how to manage medication well. I know pain and Parkinson's was a big area of research for one of our neurologists here in Calgary. So yeah, they're always doing something, and it's a good way to get involved and know what's happening with Parkinson's, but also hopefully be a part of the future in finding a cure for Parkinson's. All right, so that's kind of it about Parkinson's. I'll go through a little bit about what our organization does, and then we'll do some questions. So Parkinson Association of Alberta is a charitable organization. We are the source of support, education, and inspiration for people impacted by Parkinson disease and Parkinson plus syndromes. And we also engage in important quality of life research in Alberta. Our vision is to support people impacted by the disease today and work towards a brighter future tomorrow. Some important things to note about our organization: we are separate from Parkinson Canada. They are also doing some great work. We are just Alberta based, and we focus mostly on people in Alberta. We don't receive any government funding, so all of our work is done by fundraising and donations. And then we have offices in Calgary, Edmonton, Southern Alberta, and then we kind of cover the province as a whole with that team there. So What we kind of do, so some of our supports and services, this is what I'm responsible for day to day. So we have quite a few support programs. So we do support groups. We have about 40 across the province, and we are just branching out into the Northwest Territories to offer some support there as well. Our support groups range from in-person to virtual, depending on where you're located, and then they can get more specialized as well. So we do have a support group specifically for people who have had the surgical interventions for Parkinson's. We have a group specifically for people who have those Parkinson plus syndromes, those 4 that move quickly and that don't respond to medication quite as well. We have support groups for people who are young onset, who are diagnosed kind of under the age of 50, support groups just for care partners. So we try to really have a range and hopefully have a little something for everyone. And then our local ones are kind of based on location. So we do the major cities and then kind of some communities surrounding them. So if you're interested in a support group, just go to our website and you can see a full listing there and see where we offer some support. We also do one-on-one support. So this would be your chance to meet with myself or someone else on the client services team and talk about your journey with Parkinson's, ask questions, learn about some resources and how we can help. We are open to doing this in person, either in our offices or in your home or in the community if you're comfortable with that. We do it virtually on Zoom. We can do it over the phone. If you're interested in accessing this, you can just phone the 1-800 number that's below or email us or go online and submit a request there. And we're happy to help. This is often quite used by people. It can be a range of things. Some people call and say, I'm wondering if I'm eligible for the disability tax credit, or what is the disability tax credit? Or I was prescribed this medication called amantadine. What is that? What is it used for? What should I expect on that medication? Or sometimes people just need a listening ear to talk to someone who knows about the disease and who can kind of understand what they're going through. So that's kind of our support program. That is our biggest focus. That's kind of what we do day to day. We also have some active programming. So we have some exercise and physio classes available across the province. We have some support programs. We have voice and speech programs and cognitive programs. So again, trying to do a little something for everyone and make sure that every kind of base or impact of Parkinson's is covered. A lot of these are virtual so that they're open to anyone across the province. So if you're interested in joining, again, just call us, let us know, and we'll let you know what we have. And then we have some educational resources or programs as well. So we have printed resources. We make a magazine 4 times a year that is always on different topics related to Parkinson's. And this is available with a membership or available on our website. We also have some printed resources like one-pagers that kind of talk about different things with Parkinson's. We do webinars and presentations, so things like this to let people know about us and about Parkinson's. And then we also have some online resources. We have some videos on our YouTube channel of previous neurologists or professionals that have come in and done some education for us. And so all of our services are available to the person with the Parkinson diagnosis, but also their spouses, family members, friends, really anybody who wants to learn about the disease is able to access our services. I should also note our support services are offered for free. Our active programs often have a cost to them. We have facilitators who are coming in to do them, so they're usually to pay the facilitators, but we try to keep them at a minimal cost if we can. And then often our educational resources are available for free as well. And then this is our small but mighty team here. So if you have questions or you want to get connected to us, then you're welcome to, like I said, use the phone or those emails there and get in contact with us. And so that was quite a bit of information to pack into 45 minutes, but we can go through some questions now. And I'll stop my screen share maybe.
Thanks, Emma. That was great. So we do have a couple of questions here for you. Is there any specific, or are there any specific foods that have an impact on the disease?
Yeah, good question. There's often a lot of talk about protein and Parkinson's. So people find that protein is absorbed in the same way as the Parkinson medication. So if you're having a lot of protein and you're having your Parkinson's medication at the same time, you might feel like your Parkinson's medication, it doesn't feel quite as effective because your body is busy digesting the protein as well. So it's often recommended to try and space your medication from your protein if you can. Other than that, I know some people find that dairy impacts them, but I think that's more of a personal, I don't necessarily think it's applicable to everybody with Parkinson's. There's no specific diet for Parkinson's, which is a question we get quite often. A lot of neurologists recommend the Mediterranean diet because it's quite healthy for everyone, but I would say protein is the one that has the biggest impact. And if you're feeling constipated, then your medication also isn't absorbed as it should be. So that can impact it as well.
All right. Is there any group resource Is there a support group, resource group in Alberta for PSP?
Yeah. We just changed the date and time of it. So now I'm not feeling as confident in my answer. But we do have a group, we call it our Parkinson Plus group, and it's made for people who are living with PSP and the other ones, MSA and CBD or dementia with Lewy bodies. And I believe it's the first Tuesday of every month at 10 a.m. And it's a virtual group so that it's open to anyone in the province. But if you're wanting more information, I can send you my email and you can let me know. And I see there's another question about my email address. So I'm
That's okay. I'm
wondering.
going to add it into the
Okay.
presentation when it goes up on YouTube, but I will
Okay.
also include that information for everyone who has registered for this.
Okay. Okay.
Um, is there another question coming up? Nope. So I have a couple side questions here. Um,
Mm-hmm.
if somebody wants to do a bit more digging into, the disease itself or understand things, um, where's the best location to go that is not Dr. Google
I was going
search?
to say, please stay away from Dr. Google. Um, I guess it depends specifically what you're looking for. We have some resources available, some written ones that can be quite helpful for people. But I would say Michael J. Fox is a good resource, although sometimes their information is specific to the United States. And so medications might be different, or the way you can access service might be different. The Davis Phinney Foundation is also a really great place. They have a manual called Every Victory Counts. And it is a manual that's all about Parkinson's. It's kind of divided into sections. So you can go and say, okay, I want to know about medication. And, pages 100 to 150 are all about medication, and you can read through. So that I've heard people call it the Parkinson's Bible. That's kind of the best resource for people with Parkinson's. Parkinson Canada does have some printed resources as well that they'll mail to you that are quite good. And then Parkinson Foundation also has some good stuff too. So I would say stick to the bigger organizations and stay away from Dr. Google if you can.
Fair enough. And we didn't really touch too much on the emotional support, of family members and caregivers, and how to um, support somebody who is dealing with this, because everybody kind of, you don't know, and then you feel awkward, and then everybody feels awkward. So how
Yeah.
do you go about, gathering information and finding support in that area?
Yeah, good question. Yeah, Parkinson's is a difficult disease, and it's not just the person with the diagnosis that's impacted. Family members and friends and spouses are also really impacted by the disease, and they feel like they're walking this journey too. And so, a lot of our information is also geared towards care partners. Like I mentioned, we have some care partner support groups, both in person and virtual. And then we also have it's a one-on-one presentation, kind of similar to what we did today, but all about care partner and how to navigate the care partner journey. We also have a care partner program, a support program where we go through kind of what it means to be a caregiver, how to cope with some of the challenges, and how to be the best caregiver that you can. And so some printed resources on that as well. So we have some information, but I would also say the one-on-one support might be beneficial for care partners if they feel like they just need someone to talk to who understands the disease and understands what they're going through. I know some folks have also accessed Compass for caregivers, which can be beneficial. It's not specific to Parkinson's, but it does touch on managing or caring for someone with a chronic condition. So that can also be a helpful resource. And Caregivers Alberta has some helpful resources too.
Okay. And for the people that are watching this now and the ones that are watching this on YouTube, that are not in Alberta, can they still access your information through your website?
Definitely. Yep.
Okay.
Yeah. Information should be on our website. If you're having difficulty navigating the website, though, please just give us a call. We are Alberta based, but we'll support anybody who needs support.
Okay. And is there anything that I didn't ask that I should have?
Oh, putting me on the spot. Now I
I
can't think.
know.
None that I can think of. Those were really good questions.